So today we have Dr. Kim Shojania, Dr. Jennifer Reynolds, Dr. Mary De Vera, and Dr. Antonio Avina Zupieta. So the first question we received was, what research projects are you currently working on to further diagnose and find treatment for lupus?
I'll jump in. So what I'm currently doing on research projects for lupus, on the diagnosis, we're trying to develop what we call machine learning system, which is actually well known. For those who do not know, is you do let a computer, based on data that you have already existing, to develop a model that can tell you who's going to develop lupus at some point. And the reason is we quite often get people with antibodies, let's say ANA positive, and some symptoms. And we know the antibodies could be the first manifestation, and it may take up to 10 years to get a diagnosis. So now if we learn from a machine based on previous experience and data, we could develop what will be the best markers to predict who is actually going to develop lupus, and do not wait too long to intervene. And just being wild, I will say, if you have a model that can predict who is going to develop lupus later on, you could even start treating early with hydroxychloroquine, which there is enough evidence to suspect that hydroxychloroquine could stop the progression of lupus, and maybe even in people highly susceptible with lupus. That has been proved. At least there's some evidence in rheumatoid arthritis, and that could be the same for lupus. But this is a model that's still in progress. It depends how rich your data is. And for the treatment of lupus, we're not involved in clinical trials. I think I'll leave that to Jennifer.
How about your study on hydroxychloroquine ocular toxicity? This is groundbreaking and never done before. Your study where you're taking everyone in BC with lupus and making sure they're getting their eyes tested by gathering their data and connecting them with eye doctors.
Well, I was just following the actual question on diagnosis and treatment, right?
That's
so
treatment.
The diagnosis was one of those. For treatment, remember the big scary things for patients with lupus is, and not just lupus, but those people who get hydroxychloroquine or Plaquenil, which is very famous thanks to Trump, is the big fear of vision loss or blindness, who some people get scared with that. In reality, the effect is rare, or at least we thought it was rare, but there was a recent study in the US who showed that it was actually 20 times higher than we predict. But it has to do with the early or more technology that allows you to detect early changes in the retina. So that question, despite the hydroxychloroquine has been for almost 70 years in the market and being used for so many people, we actually don't know the true rate of actual eye toxicity. So what we're doing now is following everybody in BC who has received hydroxychloroquine, mainly lupus and rheumatoid, who has been at least exposed to the drug for 5 years, and we're going to follow them in a very standardized way with a retina specialist, just like people do in general, but this is more structure analysis of the eye, every year for 5 years. And we expect that we will be able to collect the actual true rate in the general population. So stay tuned, because you're going to get letters from for invitation to participate, or allow us to contact your rheumatologist, and you're going to get an annual eye assessment, as you usually should do, but this is going to be very structured with eye specialists. That's another project. And the last one, which is the one I presented on the very preliminary data on the COVID, we are actually looking at outcomes, but it's coming one after. We are going to do, the question is, are people with lupus who get in vaccination actually being able to mount an immune response with the vaccine with COVID? We don't know. There is a recent study published yesterday that showed that people with autoimmune diseases, let's say 10% of those people do not get the immune response that you expect from the general, compared to the general population. 1% of the general population who got the vaccine usually did not get an immune response, but people with autoimmune diseases, 10% did not get. So we're going to do that in BC, including lupus, but not just lupus. So stay tuned, because we're going to ask you to come or email you some material where you can actually pinch your finger, put a drop of blood in that, and then mail it back to us, and we will be able to measure antibodies to see if you're actually immune with against the COVID-19 virus, or the SARS-2 virus. I think those are the three most important ones that we're currently doing. And we're not doing clinical trials, so not doing drugs, because UBC is not allowing us to conduct research. There's a lot of problems to do it, and until COVID is gone, we will probably be doing clinical trials in lupus. We've been invited to participate in new drugs, which until we have it here, we'll not talk about those today.
The next one is up here. Did hydroxychloroquine truly protect against or treat COVID?
No.
No.
Is it safe for lupus patients with AIHA and
Antiphospholipid antibody.
to have the COVID vaccine? What is the percentage of having a flare-up after the vaccination?
So yes, it's safe to get the vaccine. There are current guidelines from the Hematology Society, and they're very clear that having a prior clotting disorder doesn't increase your risk for the side effects from the vaccines. So yes, lupus patients should be getting vaccinated, whether or not they have hemolytic anemia or phospholipid antibodies. I think Antonio talked a little bit about the percentage of flare. I have only seen one of my patients have a very mild flare, and I'm not totally even convinced it was a lupus flare. Is it just a side effect from the vaccine? Settled within a few days, but the vast majority of my patients haven't reported any flares after vaccine. I haven't seen as much data on that. I don't know if Antonio or Com would have.
We will do a study, and the vaccine study, we're actually going to collect data on people who may have potential flares. So I think it's low, but based on my own experience, I don't know if Cam sees more patients than I do.
I would just put in the chat that Dr. Lee from the VJ Thrombosis Clinic, who sees a lot of antiphospholipid, but also all thrombosis and platelet disorders. She says she's a platelet doctor, which is kind of funny. But she said she reviewed the data for the ministry and said that they're safe for all of her patients in the thrombosis clinic, which is like worse. They're more severe patients than our own antiphospholipid patients in general.
What are some natural pain management solutions for lupus?
So there's a little bit of evidence for omega-3s as being a natural anti-inflammatory. So I always suggest if people want to increase those in their diet or take a supplement, that's worth trying. I think that the physiotherapists do a really good job of promoting heat and ice and some really old school treatment that way. There's not a lot of evidence for some of the other supplements that I know people try. I don't think it's hard to do those studies, so it's hard to know for sure, but omega-3s are the one that I usually tell people to try.
I'll tell you that in my patients, when I used to, 20 years ago, I used to be the director of a pain clinic, and then and more recently with managing pain in my patients, I find that a few things, here are just a few overview, that coping strategies for pain management are not usually best done with medications. It's almost like we need other ways to manage. And I think the best way to manage pain, and the other question in there, fatigue, that I saw in the chat, is actually some lifestyle modification. We know that people who exercise with the 4 kinds of exercise, cardio, strengthening, stretching, and balance agility, but mainly cardio and strengthening, will reduce their pain levels and pain flares. Also, coping, and another thing they will say is, my pain is the same, but my function is better when you're starting to exercise. So I definitely would add some coping strategies that include exercise. I avoid opioids or codeine and that stuff. They seem to take away our own natural endorphins and ways that we manage pain. If you when you have really bad pain, you take an opioid like a codeine or a Tylenol 3, I think that does you a disservice in the long term. I think that there are other very good coping strategies. UVic has a pain coping strategy module that is very helpful. Anyway, that's a whole other section, to a whole other lecture, but I think with chronic pain coping strategies, the medical model of me and Antonio and Reynolds, we are not as good as what you can do with non-medicines. Is that, I don't know what you guys think. Am I being totally off, guys?
No, I think is you're right. And the key message you just said is do not use opioids.
Yeah.
It's more behavioral changes that will lead you to cope better with pain.
Yeah.
It's very difficult to take away the pain, but you have to learn strategies to cope with pain that allow you to function well. And I think that's you will not get that with opioids. Do not go that route. We just submit another paper on, if you start tramadol in people, this is not lupus, with osteoarthritis, which is a common drug used, for instance, a weak opioid, the chances of dying are higher than if you don't take it. It's in the next 12 months. So do not start on opioids. And physical activity, to me, this is, and the key in physical activity is always start slow and go low. Because as Cam mentioned, fatigue and pain are common, and it's very difficult to engage people with physical activity when they have no energy. So start slow, go low, and get a trainer to allow you to go slow.
What is your take on cannabis and lupus?
This is going to give you a quite broad of responses, and I'm going to let the other two experts go on it first.
I don't think there's any studies at all looking at lupus in particular with cannabis, so we can't quote any science for you. I have patients who find taking some CBD at night is helpful for sleep. I haven't had them have any flares of their disease. I'm not aware of any safety concerns. I have many patients try it and not all of them stick with it because sometimes it doesn't work. But I can't quote you a safety concern. I think mostly it's being used for sleep and pain. I don't think it's actually at all useful immunologically in terms of controlling the disease.
I would agree. I always, I've been around so long, and I see things come and go. Right now, I just can't believe that cannabinoids are a panacea for everything. I don't think they treat every disease out there. I don't think they cure cancer, treat MS, treat lupus, and treat everything. So, but I do think that my patients who take low-dose cannabinoids at bedtime, as Dr. Reynolds says, do have some better sleep and better, I think maybe they feel better overall, but I don't think it's a lupus treatment specifically.
I will agree. You just have to be a clarification. The CBD oil is not the THC component of the cannabis, is the one that actually works in pain and sleep. So not is the CBD oil that has low concentration of THC is the one that works. So not all cannabis is the same thing. There's two main components. It is the CBD oil that actually works, or the one that has low content of THC. The THC is the portion that makes you happier or higher in mood. So that's not the one that works. It's the other one. And I have used in some patients, and the sleep improves. And sometimes when you improve the sleep, pain also gets better.
A corollary to that, though, anyone who is wanting to use it recreationally, I don't think there's any concerns about flaring your lupus or any harm that way. So yes, if you want to treat it, you go for CBD, but if you're using it otherwise, you can use THC. It's not harmful.
Hopefully research will guide us soon too. So we're waiting for data on that.
Is there any new treatment to treat skin and dry eyes for lupus?
I was going to say, so for the skin, some of the data that I presented in my talk, the anifrolumab, and there was another drug that isn't yet available. We're hoping anifrolumab will be. They have been studied in patients with severe skin involvement. So I think that's a different question. Unfortunately, the dry eyes are a really difficult symptom to treat. And the immune treatments that have been tested have all been negative. So we don't tend to use immunosuppressive or those new drugs. There's constantly new eye drops coming out, but different people find different ones to be more effective than others. I don't think there's anything else systemic really to treat the dry eyes. I know some of the ophthalmologists are doing other treatments. You can get moisture chamber goggles and other things that are sometimes helpful. So I think working with one of the ophthalmologists that's interested in dry eye treatments is probably the way to go.
I would add that not all eye irritation is dry eyes. So I would agree with everything you said. Hydration is good. Eyeglasses with side panels, right? For when you're out walking and riding your bike. Eye drops, lid care, because as we get older, those little oily glands in our eyelids, they make, instead of oil, they make this toothpastey stuff that doesn't come out properly. So you wake up, your eyes are gritty, your eyes are a little painful, you think I have dry eyes. And that's improved by putting warm compresses on. It takes that toothpastey stuff, makes it more liquidy. And so if you put warm compresses on your eyes, you could buy those bean bags, you put them in the microwave, not too hot because it's your eyes, and you put them on your eyes 15 minutes at bedtime, you will actually have a better nighttime eye moisturizing than eye drops. Anyway, try it. I do it because I got old guy eye irritation at night too, so I like it. Anyway.
Dr. Shujana actually uses for aesthetic purposes, which is okay too.
Don't tell them my secrets, Dr. Vigna.
With your patients, where have they found success living with lupus? What are they doing?
I love this question.
I will say that to me, the most important aspect that I've seen with those is they actually empower to do things and empower themselves, acceptance and empower to get better, following recommendations, attending appointments, discuss openly their concerns is what makes them more powerful to embrace the disease. To me, this is the key component. And early diagnosis, of course.
Yeah. Mary, do you have a comment? Because I think success living with lupus is I think part of it is treating the features around the lupus that you researched, the anxiety and depression, right?
Yeah, and then I guess as someone who studies medication adherence or taking medications as prescribed, so I guess one of the cornerstones is managing lupus and taking medications as prescribed, because we've actually found some beneficial effects of lupus treatment. So for example, we just had a paper come out on the benefits of hydroxychloroquine on preventing type 2 diabetes. So we're actually doing now a study looking at does taking hydroxychloroquine also improve with depression and anxiety symptoms. So definitely taking medications contributes to success of living with lupus.
I could put a plug in for the BC Lupus Society too. I think getting support and talking to other patients can be really helpful for some people.
I get inspired by my lupus patients all the time. They come through a bad flare, they're on some immune suppressing medications, and then I'm talking to them and how are you doing? Oh, I'm good. I did this with my kids. I painted this thing, and I'm cross country skiing. I'm like, I can't believe all this stuff, and they're living their lives as best they can despite the lupus.
Lupus, the liver, and the digestive system. and their connection?
So we don't usually see a lot of liver inflammation in lupus patients. There is another condition called autoimmune liver disease. And so there's some overlap with people getting inflammation in the liver that might also have lupus. There's also, rarely we can have a little bit of leukoid hepatitis, but it's not that common. In terms of that's an autoimmune thing and not so much related to your diet or what you're eating. There's a little bit of evidence, mostly in rheumatoid arthritis and not lupus patients, that you can control your disease and the amount of inflammation with a diet that's more Mediterranean is what's been studied the most, specifically, again, looking at those omega-3s. I don't think it works for everybody, but I certainly have seen some patients where making dietary adjustments has made a huge improvement in their symptoms. But I think I go back to the last comment, so that seems to be more in terms of the lupus per se. Sjogren's seems to be kind of its own separate little box, and I haven't had many patients have success with diet, particularly. As Com said, making sure that you're hydrated will certainly make things easy, but most patients with Sjogren's have dry mouth and are drinking all the time anyways. There is some overlap from Sjogren's with celiac disease. So making sure if you have Sjogren's that you've also been tested for that, but that's more digestive than the liver per se. I don't know if anyone else wants to add to that.
Yeah, I said that autoimmune hepatitis is sometimes confused with lupus, right? Because they have the fatigue, they have joint pain, mouth ulcers, ANA, liver enzymes are a little up. So I agree. Autoimmune hepatitis is often on liver.
How can I help a loved one with lupus decrease their stress and best support them?
That's for
Maybe
Mary.
I can jump on this one. So actually, it's interesting that there's been very little research around just psychosocial supports in lupus, but one paper last year that came out, they talked about patients saying that it's actually exhausting for them to have to explain themselves and educate about the disease. So I guess the simple thing that a loved one can do is get educated themselves. And I think there's a perfect role for like BC Lupus Society to provide these avenues where loved ones can find out more about lupus, because yeah, like that paper just says that it adds to their burden and just the exhaustion of having to explain what it's like to live with lupus.
One of the comments that I sometimes hear as well is that they get told that they look well. And sometimes if you're not feeling well, it's frustrating to have to explain that just because there's nothing to see doesn't mean that you're feeling healthy. So sometimes instead of, I think a lot of times people mean well when they say that, oh, you're looking great. But if inside you're feeling really terrible, it sometimes isn't helpful. So just being aware that there's a lot of fluctuations in symptoms and that they may or may not have something that you can see to be able to tell that.
You know, I think it's hard to know what to do when your loved one has lupus or another condition. I think you can range between giving them their space and privacy or being too managey, intrusive, right? And sometimes the loved one doesn't know what they want with their partners around. So I think the best thing to do is the two of you have to communicate. How can I help you? Do you want me to come to some appointments, all, none? Do you want me to ask you how you're feeling, or is that always reminding you about this? Do you want me to remind you about sunscreen? Do you ask them, and you guys have a really good conversation and update it about what you should be doing. And this will help, I think. So some people want more. Some people don't want their loved one to see them as a sick person. They want them to, leave my lupus between me and my doctor, and you're in a different situation, right? So I think you need to talk together and figure out what the best way is to support.
Totally agree. Totally agree. Open conversation.
Oh, what's a spoon theory? I've never heard of this. That's interesting.
That's the Lupus Society in the UK put a really lovely video out, and they talked about it at the conference a couple of years ago. it's to do with fatigue and energy levels, that you are given a set of spoons each morning and you have to use them up for things like showering and dressing. And sometimes you have a whole pile of spoons and you have leftovers to help do the rest of your activities. And sometimes you really don't have enough spoons even to get your basic stuff done. But it's a really great video. And I think that I saw there was a PDF as well. And I've sent patients that way because I find it's just a nice way of trying to explain to other people what it's like to be limited by your fatigue.
What dietary changes do you recommend to the newly diagnosed? I know this has been touched on a little bit, but anything else to add?
I think from our rheumatoid arthritis and other conditions, the diet has been studied. And I think we underestimate the effect of a healthy diet, which means plant-based, avoiding fast foods and a lot of the carbohydrate-rich, sugary foods and the other foods. Plant-based Mediterranean-style diet with little bits of meat and fish, but not being too fussy. Having a little bit of wine is okay, and not avoiding things like tomatoes and, simply avoiding one or two certain things is not the answer. So doing a plant-based diet that's relatively healthy without a lot of fast foods is probably the best way to go. Obesity increases inflammation. So if your weight is high, bringing the weight down also helps with inflammation in a number of our conditions.
I think lupus patients in general have an increased risk of other autoimmune diseases, but there's not a specific link for myasthenia gravis. I don't know if Com or Antonio wants to add to that.
We see it together. We see, yes, exactly. There's certain autoimmune diseases that seem to like to go in clusters or family clusters, right? So type 1 diabetes, systemic lupus, vitiligo, alopecia areata, myasthenia gravis, yes, can often be together in people or in relations.
I think the most common one is thyroid disease.
Autoimmune thyroid, yes.
Screen all of my lupus patients with thyroid. Yeah. The one on the screen is actually not uncommon to have an ANA go negative over time. Fortunately for lots of lupus patients, their disease will also get less active over time. But I don't repeat my ANA tests because they don't follow them. They're not useful clinically, but it isn't uncommon to go negative, especially years later.
It might be that positive ANA for 30s becomes negative in those 4 cases that I gave in my talk. It might be in the not lupus quadrant as well.
So I was diagnosed with mild SLE by a rheumatologist and put on prednisone. This followed a rigorous time with PMR. He died and I was transferred to another doctor who disputed the diagnosis and said I had rheumatoid arthritis. I'm now on Humira, which seems to help a lot. Was the first diagnosis incorrect? Does the fact that Humira work dismiss the original diagnosis of lupus?
Yeah, probably.
This is quite common.
I was going to say, as Antonio said, this isn't uncommon. That time is actually really helpful. That something that looks like lupus turns out to look more and more like rheumatoid over time. I think.
Yeah. Or the other way around.
Or the other way around.
Yeah, I would say the arthritis that is very similar in both groups, and sometimes lupus may have more features showing up later, and that's when you make the diagnosis, or vice versa. You think it's lupus at the beginning because you have lots of antibodies and arthritis, but then over time you see that the X-rays show that the actual arthritis is being destructive, which is not the type of arthritis you see in lupus. So we're humans, and sometimes we give the best shot on diagnosis, and sometimes we have to keep an open mind to change. And it's a question. And again, I will say, empower yourselves. If you're not feeling better, have an open conversation with your physician and ask for a second opinion, as Cam Sujanya did in his talk. Most physicians will be okay to say, I think it will be worth. And when you come and see from the different perspective, you actually see things that the other person didn't see because you have open, fresh eyes. So empower yourselves. Don't wait 18 years and talk openly with your rheumatologist. Or you have to remember, you're entitled to find another physician if you're not satisfied with the physician you are with. Just be open about it, and nobody will get mad. We are friendly colleagues, and we like to help our patients at the end of the day. That's our purpose.
Is there a link between DLE and squamous cell cancer? If so, how can one prevent a recurrence?
For those who do not know what DLE is, discoid lupus erythematosus, which is a skin disease that very rarely progress to systemic lupus. And I actually don't know this one. Cam may know better.
I can weigh on this one. Discoid lupus and squamous cell carcinoma are not connected and not related. There's no link, but they look like each other sometimes, right? So when I see a patient, I see, and DLE is often here in the same areas where skin cancer can be. So I'm looking at the patient going, I can't tell if that's a squamous cell or a DLE. I'm going to arrange for a little biopsy. So that's what I do. Sun protection helps both of those things, by the way.
I was diagnosed in June 2020 and started Plaquenil immediately, along with 15 milligrams, that's our prednisone. I started my Coffinilot mid-January at 3,000 megagrams a day, and I'm currently at 8 megagrams prednisone. I'm still suffering with pain, stiffness, and exhaustion. My question is if it could be the steroids causing this, and as I decrease it, will improve, or can my Coffinilate take a lot longer in some people?
I guess I can start with that one. Everyone's lupus is a little bit different. In general, prednisone works really quickly, and we're using it to try and decrease the stiffness and the pain. So I actually think it's probably not the likely cause. Some people find that there's a lot of cognitive side effects with the prednisone, and so as the dose comes down, those will certainly get better. Mycophenolate can take a while. It's a couple of months isn't uncommon before we see full effect. And in fact, in terms of lupus in the kidneys, we actually don't expect to see a full response for several months, even out to 6 months before they would say that it wasn't working. But this is a kind of, exactly as we've talked about before, a case where you go back to your rheumatologist and you just let them know how you're feeling, and you can decide together whether you need different treatments, more treatments, or some other change.
Revisit the diagnosis, regroup, and then say, okay, what are we treating? What's going, what's the condition? What are the, is there something else going on, right? Like Dr. Reynolds said, thyroid disease. Is this person hypothyroid now? So I would, regroup and rethink it.
How can one differentiate between a lupus skin problem and other types of skin problems? Besides sunlight, are there any other factors that may cause skin problems? What treatments are available for skin problems?
I think this is where a good dermatologist comes in to differentiate between, just because you have lupus, not every skin thing you get afterwards is lupus. And I think having a dermatologist help. And you are more exposed to other skin conditions anyway. So certain medications can increase skin cancer risk slightly. So I think having a dermatologist help. Yeah, I think, there's so many new topical therapies for various skin conditions, and the rheumatologists like us are not the best at topical treatments for lupus. I think you need to get a good dermatologist to work in conjunction with your rheumatologist.
Were the lupus patients disaggregated into treatment regimens for susceptibility to COVID or just disease diagnosis? Specifically, is there any correlation between a particular SLE treatment and subsequent risk of COVID?
We have very few cases, and the analysis that I presented to you, that I presented two different numbers. There was 41 and 91 cases, depending on the data that we analyzed. So it's very early. We are actually doing more complex analysis grouping by drug exposure. I will be able to tell you if this is the case. But so far, the crude analysis, when we included even SARS that are not lupus, like scleroderma, Sjogren, etc., there was not an increased risk when we compare to the general population. So by answering that question, I think is already clear enough that there are not an increased risk of developing COVID in lupus or across diseases, regardless of the treatment that you have. We don't know if the same will happen with cancer. Remember, those of these medications are used in cancer or transplant patients. Maybe when we have thousands of patients or hundreds of patients with that particular drug, we may find the risk. But my preliminary data suggests that it is actually not an increased risk. I think it is not just the drug. I think people with lupus who are exposed to immunosuppressive therapies or these medications, or even cancer patients, behave better. They follow the rules better, they self-distance better, they actually very careful not to mingle with crowd samples of people with potential COVID. So I think this is the behavior. We're actually surveying this question to see if is the behavior that they actually do better, and that's the reason why they are at not an increased risk. So that's the short, medium answer.
Is the COVID-19 vaccination as effective for lupus patients as for the general public? I was told before the flu vaccine is less effective for lupus patients than the general public.
I touched this at the beginning. 10%, that was a study published yesterday, 10% of people with autoimmune diseases do not have enough antibodies titers to, at least in the lab, to, or not an adequate response to the vaccine. But this is titers. There are other things that work in the immune system. Titers is not the only thing. T cells play a big role in immunity. And I think that's another reason why people may still get protected. But they are actually, it's true, less effective, but nevertheless is better than nothing, because 90% will get protected in general. So we're still encouraged to go and get the vaccine.
I think just to add to that, that there may be some difference in terms of medications as well. And so I'm hoping that Antonio's study and some of the data coming down will show us that if we need to be more careful with patients on specific medications. And that's where we've seen that before. You know, the flu vaccine is less effective in patients on methotrexate. So if we held the methotrexate, they got a better response, which is why some of you who are on methotrexate might have been told to do that. We also have a lot of concern with patients on rituximab in terms of their ability to mount a response. And so if you're on rituximab, you for sure should talk to your rheumatologist about when to get your vaccine to maximize your chance of response. Been listed too, we just have a few patients on that.
Is it common for long haulers who have had COVID to struggle with elevated blood levels, heart palpitations, and breathing issues?
I'm not seeing these patients. I can't comment.
Neither do I.
There is a long haulers clinic, like a clinic for patients who've had COVID that's being run out of St. Paul's. So I'm not sure who this one is, who this patient is. I presume they also have lupus as well, but they are being studied. If they were interested, they could ask their physicians for a referral to that clinic. Yeah, there's one at VGH too. Both, there's a post-COVID clinic, they're called, at St. Paul's and VGH.
And Fraser Health also has that clinic too now.
Oh, good. So everyone should.
But you know, I don't know, is everyone here from Lower Mainland? I think they may also maybe from other health authorities as well in BC, right?
No, I'm from Vancouver Island.
Oh, okay.
I don't know about the island.
I don't know about Vancouver Island Health Authority.
Yeah, I haven't heard of anything or, yeah, and we're
I'll look
doing,
it up. I'll look it up while we're talking here.
okay, thank you.
You actually could probably be referred to the clinic at, on Vancouver if you wanted to.
Yeah, we shouldn't be taking the ferry. Of course, it would be essential, I guess.
I
but
think you could do a virtual visit.
Yeah, exactly.
Yeah.
Thank you. And we're doing well. I live in Parksville, and we're actually doing quite well with the, you know, the COVID sort of numbers and stuff. Thank goodness.
You are very well behaved on the island.
We are. You have no idea. And I think it's the fact it's an older population. And I live in the Oceanside area, Parksville, Qualicum, and you have no idea how good everybody is. It's unbelievable.
Go
Yeah.
look at pictures of Kitts Beach on tonight and tomorrow night.
Yeah. Oh, we go even at, I laughed one day, I was at Raft Trevor, and no kidding, everybody was spaced. It actually looked quite funny, and nobody was going near each other, and we had tables and chairs all apart. So it was quite beautiful, really. And people wear masks, even going for a walk around the ocean, you know, around the periphery.
Okay, those were all the questions that were submitted throughout the week. I know there's a conversation that's been happening on the side over chat. Are there any questions that haven't been answered or any questions that you want to ask live to our panel right now?
There was one comment at the beginning about the minimum dosage for Plaquenil. And the answer is complicated because we don't really know. There is a lot of research being done on measuring the levels of Plaquenil in the blood, and we're working on possibly getting access to that here, though we don't have it yet. So we know that we want to keep the dose below 5 milligrams per kilogram in order to prevent some of the eye toxicity. But what the minimum amount is for each person, we don't know. Sometimes I lower the dose when patients have been on Plaquenil for a really long time because I worry about the cumulative risk, and see if I can get away with a lower dose, thinking, and I don't have great data for this either, that that's going to lower their risk for eye toxicity.
My left eye is now blind. And I was on hydroxychloroquine for quite a while. I have systemic lupus and class 4 diffuse proliferative lupus nephritis. It's Eileen from the island. And I do see eye specialists, and they decided in 2016 that I should immediately go off Plaquenil, which I did. I also have been diagnosed with myopic degeneration. So it became very complicated. My right eye is also damaged, but has better vision than the left. I have just given up driving because of the state of my left eye, which is hard. But I'm very interested in what you've had to say about that. And I'd be very interested in the research that is about to be done. I think that's terrific. I don't think we can underestimate it. I was on it for many years. And to lose your vision and have vision loss is very difficult.
I'll make a comment here because it's a very common concern. So the technology that we used to do or have to screen for eye toxicity is not the same that we have now. So in the old days, and I'm talking about 2000 before 90s, 1990s, by the time you got diagnosed with retinal toxicity, it was too late. And that no matter what would you do, the progression was probably inevitable. You will still get eventually. Now, with the new screening tools that the retinal specialists are using, we are allowing to detect earlier changes. And it is very possible that if you stop at that time, the disease will not progress or the complication will not progress. This is the theory. This is the question that we will also answer. Among those who are going to identify in these 5,000 people, we think we have 5,000 people, we will see if the retinal disease progress over time after you discontinue the drug. My theory, my belief, it is that it will not progress because we are detecting very early. And that's why the eye changes or the frequency that it was detected, the rate was higher because of this new technology. So the new technology will allow us to do early screening, better diagnosis, but you will be able to stop and the disease will not progress. So I think this is a game changer. And new technology is coming up. The machine that they use to do the images of the retina are newer now, and they're coming new more. So I think this sensitivity will increase. So don't worry too much. I think as long as you're doing your eye check with the new technology, you will be safe.
Thank you.
You're welcome.
Yeah, thank you. And Dr. Avina, I actually would be very interested in this study as well, because I too, my left eye has been affected as a result, and I too have pretty much lost my sight. It has been a complication because I have multiple autoimmune diseases. One being myasthenia gravis has been diagnosed as well now. And then I also experienced a couple of years ago trigeminal was damaged because of shingles. So
Okay.
I would be
Are you
very
still on
interested.
Sorry to interrupt you. Are you still on hydroxychloroquine?
No, they stopped it because of the, I was on it twice, actually. I was put on it, and I took myself off of it
Okay, so this study
because
is
I thought
only
I
for
saw
those people.
changes in the eye.
Sorry to interrupt you. This study is only for people who are currently taking hydroxychloroquine for 5 years or more. So you will not be eligible to be part of the
Yeah,
study.
I had been on it for that.
Yeah, but now if you stop it, you're
Okay,
not eligible.
okay, I understand.
But we can arrange, if you need a retina specialist, we can arrange,
Okay.
or your rheumatologist could arrange for a reassessment. Okay.
My question refers to the vaccinations, and I know you've talked about the vaccinations, and I listened with great interest yesterday. I read about two possibilities after you receive the vaccine, which I understand it's not a true vaccine because it doesn't necessarily create an immune response. It's like, especially with the mRNA, that if you receive this so-called vaccine, that it can either do some pathogenic priming, which makes you more prone to getting more illnesses, or also there's something called autoimmune enhancement. And I believe that my lupus was triggered by the hepatitis B/C shot, because within 3 months I was out, and I've been out for like 25 years with it. And I'm extremely hesitant to get an experimental vaccination. You know, just with the AstraZeneca vaccination, in Norway has said there's more risk of having problems with it than there is of COVID. And now Ontario and Quebec and now BC has switched over to not supporting AstraZeneca. I don't know how in good conscience I can subject myself to further complications by getting any type of vaccination. I'm really concerned about this because I've had like a hell journey, and I'm so worried about COVID and B, not doing anything about it. But I honestly don't trust the vaccine companies because I think they're in it for the cash, and they don't want second vaccination, the second dose. But like you hear so much information and it's overwhelming. And I know you recommended getting it, but I just feel like it's a death sentence for myself.
I would say in my patients who have extreme anxiety about the vaccine, I don't try to persuade them to get the vaccine. I know it's safe. I know that the AstraZeneca vaccine is also safe. BC has not stopped using it. We just don't have enough. We're just going to use it for the second doses in some of these patients. But I would say if in my patients who have extreme fear about the vaccine and are very hesitant, I say, don't get it, but keep safe. Don't mix with people. Wait for everyone, and just wait. Give it time. But if you're really worried about it, just hold off but just keep yourself safe and make sure you're doing the social distancing and don't loosen it up like everyone else is going to loosen up as they get more vaccines. But don't stress about it. If this is causing you so much anxiety, make the decision now. I'm not going to get it. I'm not going to think about it anymore. And then rethink it maybe in the fall when more data is there. That's what I think. I don't know about you guys, Antonio, Jen.
I would agree. If it's this, you just have to, there's so much information, just be careful what information you trust. Okay, that's one thing. If this is what is guiding your decision, be careful what information you trust. And it has to be a reputable place. It cannot be the neighbor's experience on its own, right? So, and wait for the data. And the most important part is, remember, the purpose of the vaccine is to protect people. If you don't want it, your choice, but still protect yourself by doing what it's supposed to do. And if you don't want it to do it in a year from now, or 2 years from now, or 3 years from now, there will be people in the province or in the world who will not take the vaccine, and you will still be exposed eventually at some point among those people. Then be prepared to always wear your face mask for the next decades until you decide when you're going to get your vaccine. Yeah, if you do that, then you're doing the right thing. Yeah, exactly. That's what I'm saying. It's not going to be over, and eventually you're going to be encounter another person who may be carrying the virus because choose not to get the vaccine, and then you will be at some point in contact with them, and you may get the virus and the disease. So wear your face mask as long as you don't have your vaccine, and that's okay.
And and also, I think all the doctors here have worked on the COVID ward a few times at VGH, and we've all been fully vaccinated. I think so. And I looked at the data when I was fully vaccinated, and I was like, you know what? And also seeing those sick patients in hospital, Antonio and Jen, that were our age, right? Our age sometimes,
yes.
And now younger.
Yeah. So the risk of getting COVID is high right now, and if you get COVID, some people will do really badly. Not everybody, but some people will do really badly. And that's the people that we worried about. And can you be one of those? Who knows if you get the unfortunate event of getting the disease. But don't kill yourself of it, as Cam said.
You can protect yourself a little bit by asking those around you. You know, if you're worried about it because of your immune system, any insurance that you can have in terms of getting friends and family and your close contacts to all get vaccinated, that decreases your risk and exposure as well. So if they don't have any risk factors and they've tolerated vaccines before, that's sometimes helpful.
Well, time is up here. First and foremost, we just wanted to really thank our speakers once again for taking the time out of their busy schedules to educate our community. We will be pushing out additional education content similar to this throughout the year and next year, just because we've gotten really great feedback. Please make sure to become a member, reach out to us. Our contact information is on our website as well as make a donation, because it's all going towards research to find cures for lupus as well. Again, thank you, everyone. Have a good day.